Good afternoon, or Ohio gozaimasu, or good morning for those joining us from Asia. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thank you for joining us today for our 11th webinar of the Winter SRS webinar series. Held every Thursday between now and May 13, the new series includes 12 talks over 12 weeks. If you haven't already, I encourage everyone to visit the srswebinars.com website to review not only next week's final talk with Dr. John Adler, but also register to view recordings of prior webinars as well. And one final item of business before we get started, if you'd like to submit typewritten questions at any time during today's talk, you can do so by using the Q&A button found in the Zoom console. Time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife system, and professor emeritus of neurosurgery and radiation oncology at Stanford University. Dr. Adler.
Thank you, Mark, and I would like to thank everyone in the audience today for joining us during this very special lecture. I'm honored to introduce today's speaker. Today's speaker is Motohiro Hayashi, who for many needs no introduction. But having said that, he is one of the brightest shining lights in radiosurgery over the last generation. He has treated almost 11,000 patients with the Gamma knife at Tokyo Women's University. He is published very widely in the field of stereotactic radiosurgery, with his work being widely cited. He has, in addition, been involved in the International Stereotactic Radiosurgical Society and has helped host some of the annual meetings for that society. But over the years, he has contributed widely to the field of stereotactic radiosurgery. And I'm just delighted that I can welcome Motohiro, better known as Moto, to give today's lecture. Today's lecture is going to be entitled Radiosurgery for Vestibular Schwannomas, the Clinical Advantage to Using Pathological Microanatomy-Based Dose Planning. So Moto, take it away and teach us all something that I'm sure we're going to learn a lot from.
Thank you very much. So now I'd like to start the presentation or?
Yes, you can share your screen now.
Okay. Can you see that? Okay, thank you.
See it very well, yes.
Okay, so now I'll start. So thank you very much and inviting this great webinar. So I'm very honored to be invited. So today I'd like to talk about stereotactic radiosurgery for vestibular schwannomas, clinical advantage to use pathological microanatomy based on dose planning. So this slide is the common sense in skull-based neurosurgeons. So radiosurgery might prevent progression in size within limited period, but no tumor shrinking remarkably, no hearing preservation long time, and making strong adhesion surrounding tumor due to inflammation change caused by high dose irradiation by gamma radiosurgery, and the potential to have the malignant transformation. So common sense in skull-based neurosurgeons, large middle-sized tumor should be selected as a surgical resection. Small-sized tumors, simple observation. So on the other hand, the common sense in stereotactic radiosurgery neurosurgeons, the microsurgery can certainly reduce tumor volume, of course, but provide hearing loss in motor patients and the risk of the damage patient of this dysfunction and the hospitalization on longer time than stereotactic radiosurgery, and QOL depend on the patient. So the result of our radiosurgery neurosurgeons, small middle-sized tumors should be treated by radiosurgery, SRS. Larger-sized tumors, surgery or fractionated stereotactic radiation therapy, FSRT. So both neurosurgeons had a different opinion. So I'd like to show the first of all past practice in gamma radiosurgery for vestibular schwannomas. So you can see the past 20 years ago, we'd like to use T1 gadolinium synthesis fused with CT bone images that we have to cover the tumor with 50% isotope yellow line covering, but we'd like to focus on where is the each isocenters. So we use 8mm collimator isocenters 1, 2. So that time, so you can see we covered the tumor, not only the tumor, but also facial nodes, probably facial node running here. So and after that, so we'd like to have the CIS images. So fused with CT bone image, we are very clearly the microanatomical condition between the tumor and each nerves. So green one is facial nerve on the image of CIS, and the blue one is acoustic nerve. So acoustic nerve is including 50% dose line. So this is acceptable. But so green line is including the 50% dose line. So this is the risk of the facial nerve palsy in the future. So I say so past treatment is was not so good. So after that, so that I went to the Marseille, France. So my boss is Dr. John Regis. So he taught me very precise radiosurgery. So radiosurgery is the surgery surgery based on the microanatomy. So I'm training 2.5 years in Marseille, France. So after back to Tokyo, I published these papers, the current strategy for vestibular schwannoma, image-guided robotic microradiosurgery systems. So just installation of the APS system, robotized systems. So image-guided robotic microradiosurgery is the precise radiosurgery with APS, automatic position systems, robotic systems, using higher quality of dedicated MR images. So cellular radiosurgery, gamma surgery, as a concept of microsurgery resection. So this is the reason why neurosurgeons should do gamma radiosurgery or cellular radiosurgery. We can know microanatomy, training of the microscopic treatment. So finally, so our aim is not only control the tumor volume, but also rapidly and remarkable shrinkage potential, and prevent worsening malfunction. So this is minimum. If the tumor is shrinking very rapidly, so the nerve has a potential to recover or improve the functionally. So after that, we published the papers. So CIS images fused with, CIS images with gadolinium. So this is the left side is simple CIS. We demonstrate the tumor. So yellow line cover the tumor. So if we'd like to use gadolinium to CIS images, now you can know very well the tumor became transparent like this. And so we can delineate vital structures such as acoustic nerve and facial nerve. So we can perfectly covering the tumor and sparing 7th nerve and 8th nerve very well. So gamma plan demonstrated the 3D images very easily. So we can see the tumor here. So green line is 7th nerve. It's the separating 50% those areas. So this is the very safe and effective treatment for radiosurgery, in my opinion. And so this is a very lucky case. So Koos stage 1 very small tumors in the canalicular case. And that time, so we delineate each nerve, and we are very lucky to visualize each nerve. So example, this is a facial nerve one, cyan color is acoustic nerve, and the purple line is cochlear nerve, and the red one is superior vestibular nerve. Orange one is inferior vestibular nerve. So we can see perfectly each nerves excluding orange line. So orange line is the stop here. So it means this tumor might be inferior vestibular schwannoma. So microanatomy demonstrated so where is the tumor origin. So this is schema of acoustic tumor treatment by gamma radiosurgery. So we have the multi-isocenter treatment. So we put 4 mm collimator in the tumors, very carefully the facial nerve. So usually facial nerve is deviated to anteriorly. So we cover the tumor very carefully and not beyond the tumor edge. We don't want to make some adhesion to the surrounding tumors because 3% risk of the not control of radiosurgery of acoustic tumors. So this is our dose planning concept. And the why tumor has shrunk in size after gamma radiosurgery. Radiation and is of course triggered by radiosurgery, so cell apoptosis. Not only here, but also the tumor necrosis might be triggered by gamma radiosurgery. So we'd like to pay attention not only 50% those areas, but also higher those areas, so such as 20 gray areas, 80% those areas, because 20 gray radiation makes endothelial cells occlusion after the tumor easily have the necrosis. So when we'd like to do radiosurgery, dose planning, pay attention not only 50% those areas, but also intentionally to demonstrate 80% of the lines. So on the other hand, so we published the two papers, skull-based meningioma. So this not same of acoustic tumors, but the concept is that so we cover the tumor like this, perfectly cover the tumor, and so 80% here. So the tumor came from dura mater from here. So we'd like to put isocenter and focus on 80% those areas here. So we'd like to stop proliferation and easy to have occlusion of the feeding arteries. So unit energy, so this is a new concept in the papers. So 80% those areas much more. Unit energy is much more. So if unit energy is much more, tumor volume reduction rate is higher. So we have relation. So it means so this paper demonstrated high dose areas inside the tumor as much possible occupied is very effective. So now we'd like to apply so this concept to the acoustic tumors. So covering 50% of those to the tumors, not only, but also 80% 20 gray areas occupied in the tumor as possible. So we ISRS members and demonstrate guideline and in some years. So the summary is that so this is a common sense of radiosurgery for vestibular schwannoma treated by the stereotactic radiosurgery, stereotactic radiotherapy. So we now use 12 gray and 14 gray. So 5 years tumor control about 90 to 99%. Hearing preservation rates of 41 to 79%. Facial preservation rates are very highly, so 95 to 100%. So in a common sense, is that the tumor is easier to have the good control by radiosurgery or radiation therapy. Hearing preservation about 50% at 5 years. Facial preservation is very high. So today and my talk is limited, so I have to focus on the two topics. management of endocanalicular tumor, Koos 1, and management of large tumor, Koos 3-4. So the paper is that. So this paper demonstrates the simple observation, no treatment, a simple observation, and about 9.5 years. The paper demonstrated the result is that the tumor progression is about 40%. On the other hand, maintenance of subject hearing about 60%. It means 40% hearing loss. So simple observation is not so good choice. Marseille, France demonstrated comparing studied retina scan observation and gamma radiosurgery, not so long follow-up, but middle-term results, 3.5 years follow-up. The hearing preservation, so demonstrated, wait and see group, observation group at 5 years, 41%. On the other hand, gamma group at 5 years, 64% is higher. So when we have the patient with Koos stage 1 tumors, hearing preservation, so we'd like to recommend earlier radiosurgery using with microanatomy. And so I found that these papers and a skillful neurosurgeon in Japan, so Dr. Yamakami. So he demonstrated 44 patients, median 7 years. So surprising hearing preservation, 72% at last follow-up. So my course I recommend to younger patients with such a hearing. So we neurosurgeon special radiosurgery, hearing preservation is much more higher than the microsurgery, but we have this paper. So we have to do radiosurgery very carefully, might be the best dose planning based on the microanatomy. So now I just start to present current dose planning for small acoustic tumors, Koos 1, 2, to provide less damage to the surrounding nerves. So first of all, we'd like to see bone images of CT scan. So you can see this is actual view, sagittal view, coronal view, sagittal view. First of all, we'd like to know where is horizontal bar. So here is horizontal bar. So this is the schema. Horizontal bars is separated between seventh nerve, cochlear nerve, superior vestibular nerve, inferior vestibular nerve. Second one, we have to know where is Bill's bar. So Bill's bar, you can know very well, separated between seventh nerve, superior vestibular nerve, SVN. So fundus of the cortex meatus, there are 4 small nerves. For example, this is a patient very small intercanalicular tumor, Koos stage 1 tumors. So we can use cis plane and CT bone images. We can know where is the surrounding nerves. This is S nerve, this is facial nerve, the tumor is here. And we the final result planning 50% cavernous tumor as possible. So you can see that so corner view, the tumor localized. So inferior vestibular group. It means the tumor came from inferior vestibular nerve cis. So I demonstrate inferior vestibular nerve schwannoma suspected cases. So we can see corner view, cis plane with CT bone images, coronal view, and the actual view and sagittal view. And we have to focus on the coronal view. So this tumor is here, so located here, inferior vestibular group. So it means the tumor came from inferior vestibular nerve and getting the bigger, and finally seventh nerve is located to the anterior superiorly. And so superior vestibular nerve schwannoma suspected case. So on the other hand, corner view image is that, so inferior vestibular group has a space filled in a CSF. The tumor tail is located in the upper. So probably this tumor might be superior vestibular nerve cyst originally. After that, the tumor is getting bigger. The seventh nerve simply anterior dislocation. You can see that, so seventh nerve and simple anterior dislocation. So this is facial notch. The facial nerve is coming, entry is here, and running here, and finally the nerve is coming out from here. So we have to pay attention only this plane, this path. So in a gamma knife radiosurgery, we intentionally have a space 0.2 millimeter here, and covering tumor with 50% of the lines, and of course, a 20 grain line is occupied in the tumor as much as possible. So this is a very rare case, cochlear nerve schwannomas suspected. The tumor is extended in cochlear, and the tumor is located in the hemicostomeatus. So, but and the very amazing fact that the facial nerve should be located on the posterior superior surface of the tumors. So 95% of the tumor is vestibular schwannoma. So vestibular schwannoma demonstrated 8th nerve, 7th nerve separated. Between the two nerves, there is the tumor located. So the facial nerves usually anterior dislocation, but so this facial nerve is superior dislocation. So this is very atypical. So when you see atypical findings of the facial nerve, so you have to imagine. So this tumor might be cochlear nerve cyst originally. So cochlear nerve schwannoma is getting bigger. The facial nerve is dislocated upper. Okay, so we'd like to proceed in the management of large tumors, Koos 3-4. In the literature, Pittsburgh group reports is that so short-term results over 3 centimeters, 65 cases, median 3 years. The tumor progression-free about 90% at 2 years. Hearing preservation is 82% at 2 years. So this is not so worse. And the worst problem factor is that post-operative and the volume over 10 cc. So if the tumor needs larger, but less than 10 cc, we can have a chance to do radiosurgery for the patients. And the next paper is so Mayo's clinic reports. So a little bit longer, middle term results, 22 cases, 5.5 years follow-up. The tumor progression-free rate 82% at 5 years, shrunk 90%, hearing preservation 30% at 5 years, the facial palsy 50% is higher. So tumor progression is not so good comparing small or middle-sized tumors, but hearing preservation acceptable, but facial nerve palsy 50% dysfunction is not acceptable. So we have to do so precise radiosurgery used with the microanatomy. And the other papers, so the Italian TMC reports, the middle long-term results, 66.5 years follow-up, the tumor progression-free, 98.3% is higher. Hearing preservation, 31.3% is acceptable. But so hydrocephalus case, about 20%, this is higher. So when we have to treat the patient with large tumor, large acoustic tumors, we have to have something of the complication comparing of the small and the middle-sized tumors. And so, and I'd like to know that, so this kind of the large tumors, acoustic tumors, so we have to do those planning with a microanatomy. Sorry. So now we'd like to present the current dose planning for large acoustic tumors, Koos-3-4, to provide less damage to surrounding tissues with maximum shrinkage. So this is a case, 54 years female patients, right vestibular schwannoma. This patient is very lucky. Haussam Blackman grade 1, no facial palsy, Robertson class 2. So the patient wanted to preserve facial palsy and, if possible, preservation of hearing. So this is 6 images, actual view from bottom to the top. This is a tumor, or it's large cystic. So this tumor might compress Hughes nerve, and we cannot visualize surrounding vital structures S and the 5th, 7th nerve very well. The time we'd like to use gadolinium. So this is cis with gadolinium images, actual view. The tumor became transparent and magnified. That's actual view. The tumor is extending in meatus. The tumor protrudes posterior fossa, touch and arrived compressed brain stem. Compression fits very well. So we'd like to do dose planning 50% covering the tumor as possible. And we'd like to pay attention not only covering, but also where and how much, 80% those areas inside the tumor. So this kind of dose planning makes the tumor, we give the higher dose, higher energy to the tumors. So this tumor has a big potential to make shrinkage. So now I'd like to demonstrate each isocenter. So isocenter is many isocenter in the tumors compared to past dose planning. So because each isocenter should be located in the tumor. So if some of the isocenter is beyond the tumor, so the tumor has a potential to have the strong adhesion. If this treatment is a failure, so we need surgical resection. After radiosurgery, if the tumor has strong adhesion surrounding tissues, microsurgery may no good surgery section, so very big damage of the facial nerve or S nerve to other surrounding structures. And so we can see facial nerve at the blue one. So we have to take care of isocenter protein. So finally, we'd like to compare simple CT bone images. So this actual view from bottom to the top like this, the 50% those areas here. So this patient still has a hearing, subject hearing. So we don't want to cover in cochlear and cochlear nerve itself. And so the nerve is running here. And so this is a facial notch. This is geniculate ganglion fossa. So probably the facial running here. So we have to pay attention. 50% those areas is not involving facial nerve. So there is a space 0.1, 0.2 levels here intentionally. So this is another dose planning for the same patients. So looks like good. 50% those areas covering tumor is very well and not involving brainstem and the other structures. So it looks like very good. But so I'd like to demonstrate intentionally where is each nerves. So number of the isocenter is not so many because larger isocenters, so such as 80mm collimeters, 60mm collimeters, they're putting not only inside the tumor, but also outside the tumors. So 50% those areas looks as okay. But so each isocenter has a strong adhesion in the future between the tumor capsule and the surrounding arachnoid itself. And so you can see that. So where is 80% those areas? 80% those areas here. So very small, unscattered. So internal dose planning, so it's not so good. So it means so distal planning is not so higher energy to the tumor. So this is no good potential to make shrinking of the tumor cell. So 50% those areas looks like same, but so isocenter put in it many different ways. So we have to take care of each isocenter should be where in the tumor as much as possible, particularly anterior aspect, because anterior aspect there is a facial nerve. So we have to pay attention facial nerve. So each isocenter should not be covered facial nerve. And additionally, so 80% 20 grade run should be occupied in the tumor as possible, because higher energy to the tumor has a potential to make shrinkage very well. So this is a case, very amazing case. The patient is a professional golfer. So he suffered from imbalance. He's putting on the green. So the putting is not so good. So he is the very troublesome in mind. So after that, so he went to the hospital to the MRI. So MRI demonstrated this kind of big schwannomas. But so this is multiple cystic. The tumor compressed brainstem very well. The post ventricle dislocated, so this Koos 4. But surprisingly, Hausen-Bracken grade 1, Gardner-Wilson class 1. So he wanted to consultation to me. So we have much time to discuss with him. Finally, so he wants to become from professional golfer to medical doctor, based on according to his experience of the patients. So he wanted to change the life, and he wanted to trial the test to enter the university, medical university. But after 3 years, the tumor is a little bit bigger, and the patients demonstrated hearing loss suddenly. So the patients that wanted to be treated by surgery resection because the tumor is very large. But so I discussed with him. So I said to him, so you want to be the mega doctors. So if you become mega doctors, the facial nerve is very important. Acoustic function is very important too. So surgery resection has a risk of the facial palsy, and probably your acoustic function is nothing. So during 3 years, so that I tried to treat this kind of the previous I mentioned. So 50% doses should be the tumor covering very precisely. Each isocenter is in the tumors. 80% those areas occupied as possible. Most of the patients has shrunk with high preservation of the nerve function. So the patients selected my radiosurgery. So after 5 years, the tumor shrunk very much like this, and Hausen-Bracken grade 1, Gardner-Wilson class 1, 2. And so surprisingly, now he is a doctor. So the patient has a big risk at the beginning of the finding of the acoustic tumor, but he's very happy. So this happiness is provided by stereotactic radiosurgery. On the other hand, some of the cases of acoustic tumor after radiosurgery needs of operation. So this patient, the 84 years old man, and the Koos stage 3, because the patient has a secondary neuralgia at the onset. So this patient is very elderly. First of all, we'd like to recommend surgery resection, but the patient did not select the operation. So we tried to reduce surgery, but the tumor is a little bit larger transiently after tumor shrunk, but patient still has a treated neuralgia. So we need surgical resection. So this is operative view. So this is tumor exposure and tumor detaching from a caudal side. So this is very easily. Tumor detaching from brainstem. This is also very easily. The tumor removed inside. Very easy because tumor has no bleeding. Might be 80% was gray line, 20 gray line is very effective to the tumor necrosis. And finally, detaching from fifth nerve. So this was also very easy because facial nerve and fifth nerve, the other nerve is not covering 50% of those areas. Any isocenters is beyond of the tumors. So no strong adhesion. So neurosurgeon said common sense of the radiosurgery for vestibular schwannoma surgical resection is not so easy, very severe. But this case is very easy. So dose planning is very important, he said. So I'm experienced of the many cases of gamma radiosurgery. So gamma radiosurgery is invented from between the neurosurgery and radiation oncology. We have very many associations. So when we have the surgical cases for cochlear tumors, we'd like to delineate each nerve on those by computers. So after that, so three-dimensional images, it's very easy to take it. So this is operative view. So yellow line is the tumor, acostomiatus brainstem, and each structures we can see. And if the tumor is transparent, and 6 nerve, the other nerve, and we can see that. So now our radiosurgery based on microanatomy technique is used to the surgical resection, pre-operative planning. So now I'm doing the project and have a heavy particle ion therapy combination with the microanatomy radiosurgery systems. So now we'd like to invent the carbon knife. So because gamma ray proton beam is and the width is about 3-4 millimeter. But carbon beam is width is 1.0 millimeter, very sharp. So this is knife. So in 5 years, we'd like to invent the carbon knife. So usual heavy particle systems with frame application and rotating to like a gamma knife treatment. And so now I'm waiting a long time to come. So this ZAP system. So this is the newest one, non-invasive radiosurgery systems. So unfortunately, I did not touch directly this machine, but so I'm very happy to see the dose planning system in the computers. So the computer is very, very useful because isocenter treatment is base. So today my presentation based on the experience of gamma radiosurgery is can be applied to these systems. And so this system is very, very good, convenient for the patients. So now we'd like to wait the coming Utsunomiya Brain and Spine Surgery Institute. Maybe so this is the first installation in Japan. So Dr. Kim is asked me to do ZAP-X systems with micro radiosurgery. My friend Takashi Maruyama is now preparing instruction of the ZAP system in Tokyo Wildgate systems. So this is the Japanese maps. So Utsunomiya is here, Tokyo is here. So blue one is the potential of the installation subsystems in my mind. So first installation, these two centers is very needed. After that, so we'd like to do very safe, very effective radiosurgery based on the microanatomy. So I'd like to say that system is very useful, not only for the patient, but also for our neurosurgical staffs. So this is today's conclusion. The inclusion of the radiosurgery for acoustic tumors, the Koos one, unsubject hearing, the weight and scan. Subject hearing and middle younger age should be microgamma radiosurgery or microsurgery. Weight and scan is not so good in my mind. The subject hearing and elderly age, of course, weight and scan or microradiosurgery, the patient selection. Koos 2-3, middle size of the tumors. Unsubject hearing, any choice. Subject hearing, recommend microradiosurgery or microsurgery. Rapidly growing, recommend microsurgery. And Koos 3-4, large tumors, unsubject hearing, microsurgery recommended. Subject hearing, first recommended microsurgery. The microgamma radiosurgery will be considered if microsurgery impossible. Post-surgery resection, recommend additional microsurgery or FSRT. So this is my conclusion. Thank you very much for audience.
Thank you, Dr. Hayashi. And yes, there's a lot here. You've really pushed the limits of what we can do with radiosurgery for vestibular schwannoma using a microsurgical approach. And I salute you. And I'm going to ask you, if you don't mind, a few questions.
Yes.
First question comes from a good friend, and he wants to know what is the maximum tolerance dose that you would recommend for the facial nerve? And I'll ask this, not just the facial nerve, let's talk about the cochlear nerve as well. Is there a single point dose that you feel you can't cross? And tell me your thoughts about dosing and how that worries or affects your ability to limit facial nerve and cochlear nerve injury.
Yes. Of course, the facial nerve is healthy, not really healthy state, but so compression and too much. So if the healthy state that facial nerve, it means no tumors. The tolerance dose is about 14 or 16 grade, but the tumor is the compressed facial nerve. So it means the facial nerve became pathological status. We have to decline less than 40 grams. So if the tumor is middle size, larger size, I think in my experience, 12 grade or 11 grade is maximum dose to the facial nerve itself. And so not only maximum, but also the average dose to the facial nerve. So I'd like to decrease average dose to the facial nerve. It means isocenters not covering facial nerve very well. If the covering facial nerve looks at 50% dose is okay, but covering smaller isocenters to the facial nerve, average dose is higher. So my answer is that facial nerve, we have to imagine where is the facial nerve and not covering facial nerve, not only 50% dose, but also each isocenter not covering. And so facial nerve should be less than 12 grade. This is safer. And the cochlear itself. So Dr. Kano in the Pittsburgh University, he said so cochlear dose is a 4.2 grade. So this is one of the landmark in my opinion. So when we have to treat a patient with acoustic tumors, cochlear dose, and I pay attention. But so this is not meaning of the tolerance dose of cochlear itself. So for example, the patient with facial nerve schwannomas, over 8 grade to the cochlear nerve, but the patient has no acoustic dysfunction. So in my opinion, is that the hearing preservation factor is the dose to cochlear, not only dose to cochlear, but also dose to cochlear nerve itself. If the tumor extended to the acoustic meatus fundus, the cochlear nerve was damaged very much before radiosurgery. This kind of the patients, this kind of tumor, we cannot preserve auditional function very much. But if the patient has a space in the acoustic fundus, it means cochlear nerve is not so damaged. So this is the chance of the hearing preservation. So this kind of patients, finally, cochlear dose is not so high. So this is my opinion.
So if I'm hearing you correctly, even a single point
Single point.
even a single point
The
in the
cochlear dose
nerve,
is a single point I compare. But so it's better to covering cochlear all the delineation, and we can compare average dose, higher dose is there. But so I have no data.
are you treating acoustic neuroma all the time with a cis MRI and a T1 with contrast in all patients? Or it seems to me you could treat it without the T1 with contrast, just treat it with the cis sequence.
Okay.
So elaborate, please.
So I wanted to I want to use only 3 images. So Dr. John Reddy told me that. So one is cis plane, one is cis gadolinium, one is T1 gadolinium. Thin as right as much possible, and fused with CT bone images. So 4 images is enough.
So 4 images, okay. And you need all these sequences in part to identify the microanatomy around the nerve, around the tumor, right?
Around tumor, yes.
Okay.
And bony structure is very important. So Bill's burr, horizontal burr, and facial notch, and genicular fossa. So this bony structure demonstrated much more information.
Do you need to treat all the tumor along the facial nerve or the 8th nerve? Would you compromise coverage of those parts of tumor to try to lower dose?
Yes, but also some cases, of course, and we cannot visualize 7th nerve. The 8th nerve is very difficult, but 7th nerve we can visualize very well. But larger tumor, Koos stage 4 tumors, most of the patients we cannot visualize 7th nerve itself. That time, so we'd like to have a hypothesis that the tumor came from where. So the tumor came from inferior vestibular, or maybe facial nerve is dislocated anterior superiorly. So this plane we'd like to intentionally not covering.
So just to make sure I'm clear. So let's say you have a small intercanicular tumor, and you can infer by some of the microanatomy that you're looking at, as well as the known position of the tumor with respect to the nerves. So in that situation where you think you know where the nerve is, would you ever undertreat portion of the tumor to thereby not treat the nerve to the full extent? So do you underdose portions of the tumor to limit irradiation to the cochlea and facial nerve?
Cochlear nerve should be less than 12 gray, and the facial nerve should be less than 12 gray.
And so you will, but let's say you can't achieve that. And let's say you cannot treat to that dose to the nerve and get a certain dose to the tumor. Do you undertreat the tumor?
Sorry, I cannot catch your comments very well. So
okay. Do you have any follow-up data yet to show better outcomes with some of these approaches?
Yes, so I didn't have a final result of the Koos tumor by radiosurgery, but so 3 years follow-up. So our result is better than the others literatures.
Well, I hope you can repeat some of this anatomy when you get
Yes.
zap
Now
someday.
I'm summarizing over 10 years and the patients after radiosurgery. So my impression is that inferior vestibular schwannoma is not so good hearing preservation like the other literature. But on the other hand, superior vestibular schwannoma and space of the fundus CSF, it means no cochlear nerve damage cases might be maybe has a very good preservation rate of the hearing preservation. So
Excellent.
I'm talking in the future. Yeah.
Well, I hope in the future you do some studies with the ZapX. So
Yes,
that would
yes,
be wonderful.
I will do that.
Well, Dr. Hayashi, I thank you, and I'm sure the audience thanks you as well for a fascinating look into the microradiosurgical approach that you've really pioneered. And I look forward to learning more in the future years as you collect more data on outcome. So thank you, and thank you everybody in our audience. I wish you a great day. Okay.
Thank you very much.
Arigatou gozaimasu.